Hello. I think okay, can introduce yourself. Okay. Hi, I am Dr. Moulik. I'm a pediatric cardiologist here at Children's Hospital of Pittsburgh, and I hope that this webinar would give you some further information regarding the advances in management of pediatric cardiomyopathies. And I'm going to have some of my other team members also present some of the information in this webinar. So I'm the director of the Cardiovascular Genetics Clinic here at CHP, and one of my colleagues, Dr. Kirsten Rose-Fecker, who is going to present some of the information on advanced heart failure and transplant management here at CHP. And then my other colleague, Jessica Sebastian, she is the senior genetic counselor here in the Division of Medical Genetics and part of our CB Genetics Clinic, would present some aspects of genetics of cardiomyopathies. And I have no disclosures. So pediatric cardiomyopathies, these are very rare conditions within the pediatric age group. But once the patients get the disease, they have a pretty bad outcome, and almost 5-year risk of death is 50% in children who are diagnosed with dilated cardiomyopathy. And then we have some other subgroups of cardiomyopathy, including LVNC, HCM, RCM, ARVD that I'm going to touch upon. And so the way I look at them is, one, these are very rare, so these are medical zebras, but then they just have a bad prognosis. I call them zebra lions. So there are 5 morphologic forms of cardiomyopathies. A very common one is called hypertrophic cardiomyopathy, followed by dilated cardiomyopathy, LV non-compaction, ARVC, and restrictive cardiomyopathy. In these cardiomyopathies, especially in the pediatric age group, they have a very high incidence of genetic causes. And frequently we are able to identify familial origin of the disease. And most commonly they are inherited in an autosomal dominant fashion, followed by X-linked, autosomal recessive, and also mitochondrial. In pediatric age group, 40% of children with DCM have a familial cause. In HCM, almost 50% of children, we are able to identify other affected family members. So here you can see that this is the patient who had died with HCM, but then as we follow through the pedigree, we can identify a few other members. And this one is a form of autosomal dominant inheritance pattern based on this pedigree. And then as we evaluate the pedigrees, you can see the other inheritance patterns also. So dilated cardiomyopathy, which is the 2 common cardiomyopathies in children are dilated and hypertrophic. In dilated cardiomyopathy, the ventricle, the left ventricle is very enlarged, and the squeezing function of the ventricle is down, so systolic function is decreased. And incidence is very low, around less than 1 per 100,000, and it constitutes around 50% of the pediatric cardiomyopathies. Now, when someone gets this disease, there could be a huge list of underlying cause, and that's one of the important advances that we have had in cardiomyopathies, where we try to identify whether we can nail down what is the underlying cause. It could vary between genetic mutations in parts of the cardiomyocyte of the cell, but also could lead to issues because of inborn errors of metabolism or some genetic syndromes, or there could be a dysfunction of the mitochondria. Most patients with dilated cardiomyopathy would present with a range of symptoms. They could have no symptoms, or they could even present with acute decompensated heart failure and cardiogenic shock. And many of these patients can also have rhythm problems. This could have both AV block, heart block, or they could have a very fast heart rate, which because of ventricular arrhythmias. And some specific genes like LMNA are more associated with rhythm problems in children with DCM. And in addition to the genetic causes, there could be non-genetic causes, and these include inflammation, which could be either after a virus infection or some other kind of bacterial infection. And many times autoimmune diseases can also cause a picture of dilated cardiomyopathy, certain kind of toxins and neurohormonal abnormalities. So when we're looking at a child who comes in with dilated cardiomyopathy, our goal is to try to identify if we could narrow down the underlying cause, and then hopefully we can tailor our treatment to the underlying cause. And the therapy, there's a general therapy for all kinds of heart failure. Also, there could be cause-dependent treatment. And then in stage heart failure, we would need to use mechanical support and heart transplantation. The survival for dilated cardiomyopathy currently around 60 to 75% children, they're free of cardiac transplantation within 5 years after diagnosis. And then a fair percentage would be able to regain their function. The next is hypertrophic cardiomyopathy. Heart muscle gets very thick. These are the children who present sometimes with sudden cardiac death. And again, a huge range of genetic causes. Rasopathy is something called, which causes, the common term would be Noonan syndrome. Very common cause, especially if you come with HCM as an infant. And then we have mitochondrial diseases and Friedreich's ataxia, in addition to the sarcomeric genetic mutation. These are usually autosomal dominant mutations, and there could be different underlying cellular defects which result in this picture of a very thick heart. The treatment ranges from beta blocker therapy, calcium channel blockers, disopyramide, as well as sometimes they would need surgical resection of the thickened part of the muscle, which could cause impairment of cardiac output. And some of these patients would require a defibrillator to decrease the risk of sudden cardiac arrest. And this, unlike DCM, has a much better survival, 97% survival within 5 years and 10-year survival of 94%. And there is a clustering of deaths. One cluster is when kids are presenting in the first year of life, because their causes for this HCM, they usually fall under some of the metabolic causes. And then another cluster of deaths happens in late childhood and teenage years and young adult life. The restrictive cardiomyopathy is much rarer compared to the other two. Again, some genetic causes. We do not understand all the causes of restrictive cardiomyopathy as much. And again, symptoms could range from no symptoms to overt heart failure, much higher risk of a sudden death compared to the other kind of cardiomyopathies because of both heart blocks as well as heart rhythm issues. And the treatment here is not as advanced as some of the other cardiomyopathies. So there's a very early consideration of heart transplantation in this patient group, and also many of them would require defibrillator placement. The medical treatments, they don't seem to help with the disease outcome a whole lot. Another common kind of cardiomyopathy called non-compaction cardiomyopathy. Many of you might have heard of this as LV non-compaction. We are increasingly diagnosing in children. And here the heart muscle seems to lack the compaction within the left ventricular muscle. So you'll see a lot of a spongy appearance. We call it increased trabeculations. A common condition which is associated with this is Barth syndrome, but many of the children with LV non-compaction would have a dilated or enlarged heart and may look like non-compaction with dilated cardiomyopathy. Sometimes they're not enlarged, but they just have a thickened heart muscle, and they could be non-compaction with hypertrophic cardiomyopathy. Again, the symptoms could be no symptoms versus severe progressive heart failure, which could both be systolic and diastolic dysfunction, heart rhythm issues, as well as they could have strokes because clots can form in these recesses within the heart muscle. And the treatment, again, is directed at heart failure treatment, but these patients do require anticoagulation if their heart function is decreased. And then if it is end-stage heart failure, they would need cardiac transplantation. The outcomes, this has a survival, I would say, similar to that of DCM, and especially when they end up getting an enlarged heart. But the specific outcome of LV non-compaction depends on what subtype of LV non-compaction these patients have. If they have a hypertrophic or a dilated, or they have more rhythm issues. So in cardiomyopathy, one of the very important things that we realize that it is important first arrive at a diagnosis. So recognition of symptoms of heart failure is very important. So every physician, including the primary care physician, needs to have a high index of suspicion and recognize there could be red flags in symptoms of common childhood illnesses, because many of these children are not diagnosed initially, and sometimes the diagnosis is missed, and then we have late presentation where outcome is worse. So the symptoms depend on the rate at which heart failure develops, and also the age at presentation and the underlying cause. So for young infants and children, it's very important to realize that the signs of heart failure can mimic the common childhood diagnosis, like bronchiolitis, pneumonia, failure to thrive, or gastroenteritis. And there are some red flags which will tip off the physician saying that this may not be, it might be mimicking bronchiolitis, but this could be more like heart failure. And usually we look for tachycardia, like increased heart rate out of proportion to the clinical illness. If there is a gallop rhythm when we're listening to the baby, new onset of tachy or bradyarrhythmias, a very fast heart rate or slow heart rate. Or suppose somebody comes in with dehydration but is not responsive to fluid bolus, or recurrent bronchiolitis pneumonia. These are the red flags if the heart looks enlarged in X-ray. In older children, it could be a wide range of how they present. They could have no symptoms, or they could just show as decreased exercise tolerance compared to before. They could present with just palpitations, a fast heart rate, syncope, like when they faint or have near fainting episodes, and then some abnormal findings on their physical exam, or decompensated heart failure with shock. And sometimes we could even see them coming in with resuscitated sudden cardiac arrest. So it's such a wide range. And again, you need to have a physician who has a very high index of suspicion to make sure that the conditions, the cardiomyopathy, is diagnosed at an early stage. There are two basic screening tests for diagnosing cardiomyopathy, and these are available in most medical centers. And one is where you would have an echocardiogram where we look at the heart function, and this is a patient who has LV non-compaction. You can see the increased tuberculation. You can see how the heart is enlarged and is not squeezing very well. And the other tool is EKG. In this EKG, actually, this was a child who presented with a dilated cardiomyopathy, but when we paid closer attention, we could see some changes which told us that this child had an abnormal origin of the coronary artery coming from the pulmonary artery. So it's, again, very important to pay close attention to these two screening tests, which would then help us arrive at a diagnosis of cardiomyopathy. And then some of the advances in imaging, these are very important with respect to trying to identify the severity of the disease, as well as diastolic function, systolic function. Sometimes this is called tissue Doppler imaging. And then the other imaging that we do in advanced echo is strain imaging. And sometimes this might be the first tip-off when strain is abnormal, and the rest of the function might look normal on the rest of the standard echocardiogram. And this could tip off that something is not right with the heart. Another key important imaging aspect of cardiomyopathy is cardiac MRI, and it complements echocardiography, and it has a better characterization of the heart muscle and function. And it can give us information which is critical both for diagnosing as well as prognosis. This is a child who had myocarditis, you can see these areas where you have enhancement with gadolinium, and this patient had presented with dilated cardiomyopathy picture. But this is something which a lot of times recovers, and making this kind of diagnosis helps us with the future management as well as prognosis. And there are many other cases where MRI is a useful tool in ECM, in HCM, and ARVD, and LV non-compaction. So it's a very critical imaging tool now in the current era. And in addition to genetic causes, a key important thing that we need to consider in children when they come with cardiomyopathies is metabolic and syndromic causes. Neuromuscular, metabolic, mitochondrial, and syndromic causes, they're very important, especially in infants and young children. And around 40 to 50% of children with hypertrophic cardiomyopathy have an underlying metabolic or syndromic cause. 8% of children with DCM have underlying neuromuscular disease, HCM around 10%. And then when we look at infants with cardiomyopathy, they have a much higher, almost 30% of infants with cardiomyopathy will be able to identify either some kind of inborn error of metabolism, mitochondrial disease, or malformation syndrome. And this again just gives you a little breakup of the different causes of cardiomyopathy, but you can see that a huge chunk, almost 2/3 of the patients, we still do not understand what the cause is. And this is the group that we are trying to target. Hopefully that increased genetic testing would help us identify what could be the underlying cause. And the same with hypertrophic cardiomyopathy. Again, I wanted you to focus on this yellow pie of this. So this was a cardiomyopathy registry for children in the United States, and only 14% of children with HCM were felt to have a familial form of HCM. But the reason for this low number was because their family members just did not undergo echoes and EKGs to test for HCM. And this is a group in London where then once a child was diagnosed with HCM, they looked at all the other family members, and suddenly they found that there were many family members who just did not know they had HCM. So it's again very important that once you have diagnosis of HCM, all the at-risk family members should undergo clinical testing. And very important to have metabolic testing for inborn errors of metabolism. The common categories of inborn errors of metabolism which can cause cardiomyopathy are those which are result in problems of energy metabolism, some storage disorders, and lysosomal disorders. And the reason it's important is because many of these have now cause-specific treatment, which can include enzyme replacement therapy, bone marrow stem cell transplantation, or liver transplantation. So it's important we do not miss an underlying metabolic cause. Neuromuscular disorders, again, a very important cause. Muscular dystrophies are frequently associated with cardiomyopathy, and as all patients with neuromuscular dystrophies should undergo evaluation for heart function. The features of many of these muscular dystrophies are similar, but the management could be different. So again, the genetic testing is very important when we suspect somebody has an underlying muscular dystrophy. And next, I'm going to have my colleague, Jessica Sebastian. She's a genetic counselor who does a lot of the genetic testing, and she would talk a little bit about genetic testing in cardiomyopathy.
Hello, as Mousumi mentioned, my name is Jessica Sebastian, and I work as a genetic counselor here in the Department of Medical Genetics, but I also see patients with her and some of my other colleagues in cardiology as well through the cardiology clinic. So genetic testing is a really important part of, and it's becoming a growing part of the management and diagnosis strategy in individuals with pediatric cardiomyopathy. So we know about roughly 40% of children with cardiomyopathy will have what's known as a positive mutation on a cardiomyopathy gene panel, or they might even have an affected first-degree family member with cardiomyopathy upon clinical screening of other family members. So genetic testing can help confirm an underlying concern for a neuromuscular condition, metabolic disorder, mitochondrial disease, or something, some other syndromic cause for cardiomyopathy, particularly in children that present really in infancy or very young, but we've also diagnosed kids that are older and even adults as well. So the testing usually is either done on a blood sample or a saliva sample. Some commercial, there are many commercial labs that offer genetic testing, and these are now, this day and age, next generation sequencing tests that are available. These tests can include panels where we look at over 60+ genes that are known to cause different types of cardiomyopathy. And then depending on the child's medical history or the individual's medical history, we could even look at or consider doing additional genetic testing if we were concerned about a neuromuscular condition or a mitochondrial disease. It's important to note there's no current panel that's entirely comprehensive when a child is diagnosed with cardiomyopathy. And that's just because we don't fully understand all of the genes that lead or predispose individuals to developing cardiomyopathy. So there's a lot of information in our DNA and our genes that we're still learning about. And as time goes on, we're identifying new genes and new reasons for why children and individuals develop cardiomyopathy. Exome sequencing is a test that we will sometimes consider, especially in kids that are really critically ill and coming in, in a very concerning state. And so this test is a really comprehensive look at our DNA and our genes. And the benefit to this is that instead of having to think about doing multiple gene panels or waiting for a test result to come back and it's possibly negative and then thinking about doing another test, this allows us to kind of do multiple gene panels at once. So it does have a faster turnaround time overall instead of doing multiple panels. And it allows us to look at multiple different causes of cardiomyopathy. So this is quickly becoming a more recognized and utilized test in kids that are really critically sick. This type of testing is also possible in a matter of days to weeks, depending on how it's ordered and through what avenues. And sometimes that can be really important in deciding which management strategies that the cardiologists are going to use. So as Mousumi mentioned earlier, most of the time HCM and familial DCM is inherited in what we call an autosomal dominant pattern. So that just means that we know that an individual has about a 50% or 1 in 2 risk to pass on that trait or their genetic mutation to their children. And that 50% risk is independent with each pregnancy or each child in the family. Other inheritance patterns we can see include mitochondrial inheritance, autosomal recessive, and X-linked inheritance. Because most of the time we see that HCM or the cardiomyopathies are inherited in this dominant pattern, that also means that the parents could also potentially be at risk. So it's part of our recommendations that when we diagnose a child with cardiomyopathy, that the parents undergo a cardiac evaluation. And we often recommend that that be done through a cardiologist that specializes in cardiomyopathy. So I like to use the analogy that some of the subspecialties in medicine are kind of like fine car dealerships. So you wouldn't take your Audi or your Porsche to a Volkswagen dealership for a checkup. You would want to take it to the experts. And so we recommend the same thing be done for parents or family members that were concerned could potentially have cardiomyopathy but not be diagnosed. We generally recommend that all first-degree relatives of the individual diagnosed with cardiomyopathy in the family be tested. And so this is kind of like concentric circles within the family. First-degree relatives for a child would include siblings, potentially, but most importantly, parents. We've also sometimes recommended or encouraged aunts, uncles, cousins, as well as grandparents to get screened based on what we learn as other family members are tested and undergo cardiac evaluations. So some important aspects of genetic testing include that a negative or what we consider to be a non-diagnostic test result don't necessarily exclude that the diagnosis of cardiomyopathy in the child or individual isn't genetic or isn't inherited. And that's just because we have a real limited understanding of what necessarily causes cardiomyopathy, and there are many genes that we have that we're still learning about. There is something that we call a variant of unknown significance that can pop up on testing. And these are basically genetic or DNA changes or variations in the DNA where we don't have enough clear-cut evidence in the medical literature to say that's causing the cardiomyopathy in the family. And so when we find variants of unknown significance, we don't necessarily treat this as if we have an answer. Such variants, even in genes that are implicated in cardiomyopathy, we don't feel like we have enough information to really allow us to determine who in the family needs to be screened and how frequently or who's at risk. So again, we're learning about our genes and what our bodies do, and therefore over time it's really important to think about revisiting genetic testing with your child's cardiologist or even your own cardiologist, because we learn new information constantly, and it's constantly evolving. So children that we tested or did genetic testing on 10 years ago had quite a limited set of genes in comparison to what we test for these current days. So if your child had genetic testing many years ago, or even yourself, it's worth bringing up with your cardiologist to see if there's the potential for additional testing that should be considered. Some people worry about, or they're concerned about, insurance discrimination with genetic testing, and to that effect, there's a federal law that prohibits discrimination for health insurance purposes or employment for individuals that may be at risk for developing cardiomyopathy based on their family history or genetic testing results. This law is called the Genetic Information Health Non-Discrimination Act, and we call it GINA for short. And it's been in place since 2008, and it is independent from the Affordable Care Act and Obamacare. I'm going to turn it over to Dr. Rose Felker. She's one of our cardiologists as part of our heart transplant team, and she's going to go over some more information for you.
Thank you, Jessica. So I'm going to talk a little bit about the cardiomyopathy clinical services offered here at Children's Hospital Pittsburgh, as well as some of the advanced technologies and therapies we have. So our cardiomyopathy team is a group of specialized cardiologists. There are 5 with specialty training in heart failure and heart transplant. In addition to seeing a cardiologist, patients may see one of our pediatric nurse practitioners, a nurse coordinator, and if they need to be admitted to the hospital, there's a dedicated inpatient service run by the specialty team. Our patients come from Pennsylvania and the surrounding states, but we do have a large referral base, and we have patients from all over the United States and international pediatric hospitals represented in our population. We have multiple different sites that patients can be seen to ease convenience for families, including our Lawrenceville, our main hospital clinic, as well as children's clinics in the south, east, and north locations. And appointments are available 5 days of the week. The standard of therapy for pediatric heart failure is with medication therapy that can be taken at home. And this is often how patients begin on heart failure regimen. So this is done in a stepwise fashion depending on patient symptoms. Our standards of therapy, as Dr. Moulik mentioned before, include ACE inhibitor therapy, which allows for both lowering the blood pressure and decreasing the amount of work of the heart, as well as helping with heart shape and function, as well as beta blocker therapies and aldosterone antagonist therapies like aldactone or spironolactone. Often we have patients who have symptoms despite this medication regimen, and that's when we consider whether or not more advanced options may be necessary. Sometimes patients need to be admitted for a tune-up or adjustment of their medications to help relieve the symptoms that they're having from congestive heart failure. And sometimes they may need to be admitted for a more prolonged period of time for use of a continuous inotropic drip, or even consideration of advanced therapies like a ventricular assist device pump or heart transplant consideration. In addition to these standard therapies, we also offer, as part of the paradigm heart failure trial is an adult trial using a medication, which is a novel agent called Entresto or sacubitril valsartan, which is a combination of medications which were shown to reduce the risk of hospitalization and mortality in adult heart failure patients. Similar to that study, we were participating in a pediatric study called the Panorama HF study in pediatrics, but recently this medication has been approved for routine pediatric use, and we're using it in a lot of our patients. We our therapies include continuous drips, as I mentioned before, evaluation for inborn errors of metabolism or secondary causes where cardiomyopathy is secondary to an underlying genetic disease, as mentioned before. And we often coordinate with other pediatric subspecialties to minimize the effect of heart failure on other organs, as well as to optimize the care of the patient. We also believe in use of physical and occupational therapy to help patients get as strong as they can and help with cardiac rehab, and have intensive both inpatient and outpatient programs. In terms of advanced therapies, the picture that you see on the right-hand side of the screen is ECMO, or extracorporeal membrane oxygenation. This is offered relatively widely, but we are a center of excellence in terms of providing ECMO support to pediatric populations, and this can be done in patients with cardiomyopathies or congenital heart disease. This is typically reserved for patients who are end-stage cardiomyopathy or need a lot of support after an acute event. We also provide ventricular assist devices, or VADs, which are pumps that help with heart function. These VADs, I'll show some pictures in a moment, can be either used within the hospital setting, or patients even can be discharged home on ventricular assist devices. And our center has done 13 devices since 2017, and we continue to increase this number every year. We use these pumps in patients who have severe end-stage cardiomyopathy, typically as a bridge to either heart transplant to help maintain their heart and lung health, to get them to the best shape possible prior to heart transplant, or to help the heart recover if we think that that's possible. Additionally, in adults, these VADs, or ventricular assist devices, are often used as destination therapy, meaning that patients would be discharged home with no intent for other treatments in the future, but to decrease their symptoms from heart failure. This is a picture of a common, on the left-hand side of the screen is the Berlin Heart X-Core VAD. This is a type of VAD where the pump is outside of the body, and patients on this type of VAD are typically smaller and need to be supported within the hospital. There are also other devices like the HeartWare and HeartMate 3 device, which can be used outside of the hospital additionally. Typically, these are reserved for larger patients, and the pump is actually within the body and can be unattached from a machine or other things on battery power for several hours. So we have patients go to school and have normal quality of life outside of the hospital with these. This is a picture of the HeartWare VAD. As you can see, the actual machine itself could fit in the size of your palm, and it has a little rotary motor in it that's implanted into the apex or bottom part of the left ventricle, and then a tube brings blood after it's been pumped by the VAD itself to deliver it into the aorta to bypass the failing heart and provide good output to the body. In heart transplant, we reserve for patients with severe refractory heart failure where other management options have been exhausted, and this is really a therapy of last resort for us. The goal of transplant is to restore a good quality of life and lengthen life for the patients, but it's not a permanent solution. And we'll talk about that in some upcoming slides. Patients with heart transplant require lifelong medication therapy and have high risk of infection, renal disease, malignancy, and other complications. And their survival is limited by how long a heart graft can last. In any patient who are considering a heart transplant, there is an extensive evaluation process that can be done either on an inpatient or outpatient basis, and that is a little bit individualized to each patient. In terms of heart transplants at our center, we've performed over 300 heart transplants at UPMC Children's from 1982. And each year that number varies a little bit, but we're considered a medium to large size center in terms of the number of transplants performed here. This slide represents the indications for heart transplant in our population, and I apologize that some of the labels are missing. This shows the patients who received heart transplant from 2016 to 2018, and about 44% of those patients were transplanted for failed congenital heart disease, surgical repair, or inoperable congenital heart disease, while the remaining 56% were transplanted for some form of cardiomyopathy. And I apologize, I'm having trouble advancing the slide. There we go. So talking about complications after heart transplant, the complications are shown here on the left. The most common complication in patients with a heart transplant, because of the need to suppress the immune system or the body's natural ability to fight infection to prevent rejection, is the risk of infection. And in the pediatric population, infection is quite common. So you see from this graph here that almost every transplant patient has had a serious infection after several years of after transplant. There's also other risks which are seen less frequently than infection, but are more serious. Chronic kidney disease, or CKD, which is represented by the blue squares, is seen in a large percent of our population after a number of years. And this is typically in some part related to some pre-existing kidney disease before transplant, but is certainly exacerbated by the medications required to maintain a heart transplant function. Additionally, there's a type of malignancy and then coronary disease of the transplanted heart, which is typically the thing that limits the survival of the actual heart graft. Survival of heart transplant patients has gotten better over time, and the graph that you see on the right-hand side of your screen shows that these patients are able to enjoy a very good quality of life. In the current era, the median survival for pediatric patients with a heart transplant is more than 18 years after transplant. And patients who are transplanted for cardiomyopathy who are transplanted as young children tend to have better survival. This again is a graph showing how survival is improving over time. The purple bar on top or line represents the most recent era of pediatric heart transplant, which shows by far the best survival as compared to previous eras. So in terms of other things that we offer here as part of our heart therapies, including participation in both cardiomyopathy and heart transplant clinical trials, are nutritional management, enzyme replacement therapy, both hematopoietic stem cell transplant, orthotopic liver, and orthotopic heart transplant. And you can read more about services that we offer by following the link below. Thank you for the opportunity to do this webinar, and I'll turn it over to all three of us for questions.
Great. This is a very complex topic, so any questions which come up, feel free to ask, because it's very difficult to cover all of these the extensive topic in just this 30 minutes talk. But hopefully, if you have individual questions, we should be able to answer. You're looking for the questions. Try to make sure that we have our. All right, perfect. Okay, so this is a question from Mr. Feeney, and he's asking, is cardiac MRI possible in young patients who cannot be sedated due to dilated cardiomyopathy? For dilated cardiomyopathy, MRIs, in young kids, we would need sedation. So we would not sedate the patient for the sake of just doing the MRI, unless the patient is already intubated. But in those conditions where we feel that we can safely sedate a child, and the MRI would give us added answers that we feel would be critical for changing management in the patient, that's the only tiny subgroup that we would end up wanting to do sedated MRI in a child with DCM. And the next question is, I'm sorry.
It doesn't say the name.
Okay. Is VCL still a variant of unknown significance? So VCL, this is the gene name for the full term for this gene is vinculin. And vinculin is actually an important protein within the cardiomyocyte. And we know that in some patients, VCL mutations have been reported both in HCM patients and DCM patients. The issue ends up being whether we have the strength of evidence is strong enough to call it pathogenic or likely pathogenic. Just because these are rare, this is a rare gene, it counts probably less than 2% of DCM patients where we have found a VCL variant. And in the absence of strong corroborative evidence with respect to segregation within a family or multiple affected families, it ends up being still mostly in the category of VUS when we identify a VCL variant. And that can change when there are clinics which are looking at the whole family. And if you're able to figure out this variant within the family, it segregates with the disease. That means we have multiple affected members in the family, and those members who have the disease also carry the VCL variant, and those who are not affected do not carry the VCL variant. That's the kind of data that we would need to further classify. And many of the genetic testing companies actually do offer us the ability to do this variant classification. So the family-based testing would be critical then. And I'll let the next question go to Jessica.
So the next question we have is, what is the cost for genetic testing, and will my insurance pay for it? So it's kind of really dependent on what your particular insurance plan is. We find that sometimes, depending on the type of plan you have, genetic testing just isn't a covered benefit. And that's something that you could easily call your insurance company and ask them if it is. If it is, there's usually pretty specific guidelines in terms of when they'll cover it. And most of the time, if your child or yourself have been diagnosed with cardiomyopathy, most of the major insurance companies are willing to cover the cost of genetic testing. Subsequently, if you have a family member who has been identified to have positive genetic testing, most insurance companies will cover the cost of their family members testing. The family members that are getting tested, their insurance companies will cover that cost as well. So usually when you're doing genetic testing, the insurance companies often do require pre-authorization, and that's something that if you meet with a genetic counselor, we're often able to help facilitate that process and work on getting or finding ways to get the testing covered and potentially at a out-of-pocket cost that would be affordable for your family. The other question that came up is, if a gene is found to be the cause of my child's cardiomyopathy, does that mean for the rest of my children as well, and do they need to be tested? So the answer to this is that because of that 50-50 risk for each child, we often will recommend testing for first-degree relatives of that child. So we often will start to see if it's something that was inherited from a parent, and that includes having the parents undergo their own cardiac evaluations, as well as genetic testing for that change that was identified in their child. And then if the parents test negative, it's a pretty small possibility. So we usually quote between like a 1 and 3% risk for other children to have that same DNA change. And that's just because when we do DNA testing, we're testing either blood or saliva. And sometimes what we see is that that DNA mutation in a parent is only present in some of their cells in their body. So we call that mosaicism, and that then presents a small likelihood that we could see that in the other children in the family as well. And so sometimes we'll recommend, just to put it to rest, to doing the testing on other children as well.
So next question is, are there any emerging genetic therapies from new techniques such as CRISPR? And thank you so much. And we are happy that we're doing this webinar, and this was one of the audiences just thanking us for doing this webinar. There are some emerging genetic therapies which are arising, which with respect to CRISPR, we have not specifically done it in human patients. I'm sure the trials will be coming up. We have one gene therapy which is starting off in patients with Duchenne's muscular dystrophy. It's not a trial by our center, it's by one of the other centers. But I'm thinking that within maybe the next 10 years, we will start seeing significant application of this CRISPR technology, which we have found that in the preclinical studies, where once the safety issues have been addressed in some of the larger animal models, we should be able to transition this to humans. One other question regarding going to the utility of MRI in a very young child with DCM. So long as we know for sure that the coronary arteries are not a problem, because coronary arteries can mimic DCM. And I've seen several of our patients, maybe 3 months or 4 months, were presenting with a dilated cardiomyopathy. And we thought that even on the echo, the coronary arteries were fine. And it wasn't until we went to an advanced imaging, like either a CT angio or an MRI, where we were able to diagnose that this was a coronary artery anomaly, which we could surgically correct. So I think that's one important thing that we need to make sure in every infant who presents with DCM, we are 100% sure that a coronary artery anomaly is not there. And the other place where it can help sometimes is diagnosis of myocarditis. Sometimes the treatment is not going to really change, but the critical thing in the DCM patients, especially young babies, is making sure coronary artery anomalies aren't there, because that can be surgically corrected and completely change the patient's outcome.
Okay, so there was a question from the audience. If my child gets a heart transplant, how long is the heart expected to last? That's a great question. I think it varies very much dependent on how old the child is at the time of heart transplant, and also the underlying reason for which they're being transplanted. We know that patients that are transplanted for cardiomyopathy rather than for failed palliated congenital heart disease tend to have a better survival after transplant. And we tend to speak in averages because we have some of the initial patients transplanted as infants have survival that is hitting the 25-year benchmark, which is kind of the length of our follow-up at this point. And some patients, unfortunately, who may be higher risk candidates will not have as long survival. So it very much depends on a number of things, pre-transplant. And other organ health is a big factor that can affect that. How well the kidneys and the liver are doing, and are we able to have those functioning better? How old is the child? Is there the presence of antibodies, which are proteins that could exist against donors in the population that could complicate the transplant and increase the risk of rejection? And then also a lot depends on care after transplant, how adherent patients are to medication therapies to prevent rejection, and follow up with us.
So one of the other questions that we got is, if someone's interested in genetic testing, what would be the best way to go about doing that? I think the short answer to this is to talk to your cardiologist if that's something you're interested in, depending on where you're located at. Here in Pittsburgh, We have a cardiogenetics clinic that we run, Mousumi and myself, where we're available to sit down and meet with you and walk through the testing and what that would look like, as well as looking at your family history and walking you through who in the family might be at risk and who might benefit from a cardiac evaluation. If you're outside the Pittsburgh area, just maybe talking to your cardiologist about this, they might be able to identify resources locally within your own center. There is also a group called the National Society of Genetic Counselors, where you can Google that and find our website, and they have a database of all the genetic counselors that are part of that group, and a lot of them have their contact information available that you could look up and figure out a way to go about doing that if you want to personally meet in person with a genetic counselor. Some of the labs also offer telehealth visits, so you can go on their websites and schedule a telehealth appointment with a genetic counselor, and they can walk you through what the testing process would look like from there.
The next question is, has the incidence of various forms of cardiomyopathy changed in the last 10 to 20 years? So specifically looking at the pediatric population, based on the different epidemiologic studies which have come over the last decade or 20, and we compare different things. There's a study done in Australia, there's a study done in Finland, there is our PCMR registry. I would say for all the HCM, DCM category, the incidence is pretty much the same. What has changed is our ability to identify the underlying cause. And that's where we say, within the HCM group, are we seeing more familial HCM or more genetic causes of HCM, or within the DCM group, are we seeing more familial DCM or more genetic causes of DCM? Yes, because we are able to diagnose that with our current etiology-based diagnostic techniques. The one form where we probably might be seeing an evolving incidence is the LV non-compaction cardiomyopathy, because that is something which I would say even 20 years ago was probably diagnosed either as dilated cardiomyopathy or hypertrophic cardiomyopathy. And nowadays we have the ability to recognize this as a separate condition. Do you have a certain?
So there are both quantification parameters based, and Mousumi and I can share this question. There are certain quantification parameters both based on cardiac MRI and cardiac echocardiography, which compare the inside or the endocardium, the part that is loosely packed compared to the part that is densely compacted, which makes a difference between hypertrabeculation versus non-compaction cardiomyopathy. I don't know if there's something.
I think it is a field which is still a lot to learn. But the way I look at non-compaction, I think it's a spectrum. There is something which is normal, and then there's something which is not normal. So, and within so some people use the ratio of 2 to 1 as the critical diagnostic criteria, but in children, a ratio of non-compacted to compacted as low as 1.4 to 1 also has been seen in patients who were found to have LV non-compaction with respect to having decreased function, a dilated heart, or a hypertrophic heart. So and then I have seen patients with LV non-compaction who have the true strict criteria, 2 to 1 or more, with the non-compacted compacted, but they have a completely normal heart function, they don't have any rhythm issues, and those patients, we say, you are the isolated LV non-compaction, and we don't restrict those patients, even though we might end up doing some family evaluation. The only group that we end up chasing a little bit more within the non-compacted group is where we start seeing decreased function, either systolic or diastolic dysfunction or rhythm issues. So this is, and I would say that this is a field where the answers are going to evolve because we are still learning about non-compactions.
All right, I think we do not have any more questions. So thank you for watching this webinar, and please feel free to reach out to us if you have any other questions that you can think of.
Yeah, and we'll encourage, any kind of questions that you have, you could actually reach out to us through the CRDT website, and we'll be very happy to answer any additional questions if somebody has. And thank you so much for attending.
Thank you.